Hello everyone, this is a video lecture recorded for the Artificial Intelligent Planning course in the online learning community of Coursera. The topic of this talk is how to use AI planning in medicine. Okay, something about me before starting. I got my PhD in computer science less than 2 years ago in the University of Granada in Spain. I developed several knowledge engineering techniques for modeling, planning and scheduling domains using the HTN paradigm, and I used these techniques in 3 different domains: in e-learning, healthcare and business process management. Now I'm doing a postdoc research fellowship in the University of Haifa in Israel, and I'm working in a very interesting project called MobiGuide, which is aimed to create a clinical decision support system for physicians and patients to manage the care process of 2 different diseases, gestational diabetes and atrial fibrillation. And the idea is to use this system anytime and everywhere. So I will start showing several applications in the real world of how to use AI planning in the domain of medicine. So one example is how to schedule the beds that are needed in an hospital for all the patients that come on a daily basis. Another example is how to use AI planning for conducting clinical trial protocols and comply with all the requirements that are specified in these protocols. AI planning has been used also to control the state of patients in intensive care units. It also has been used to evaluate the risk and the consequences of a specific treatment, improving the shared decision-making process between patients and physicians. Finally, it has been used to prepare treatment plans for the actions that need to be carried out over a patient. This topic is the center, the focus of this talk, as you will see in a few slides. But before, people may think that applying artificial intelligence to medicine is not appropriate, and many people don't trust computers that much. So I can show you some numbers about the estimation of medical errors that are committed by physicians. This is a report of the Institute of Medicine, where between 44,000 and 98,000 deaths were estimated each year in US hospitals, and 1 million injuries also are estimated each year in these hospitals. Then a follow-up study found that medication errors are among the most common medical mistakes, and they could harm at least 1 million people every year. So it is clear that physicians need support for their actions, and in the medical scope there is a relevant movement known as evidence-based medicine. So this paradigm tries to collect the best evidence for treating patients with specific conditions. Then a set of experts collect all this information and put them in narrative clinical guidance and protocols. They use these guidance and protocols with the idea of improving the quality of the care process, the idea also to reduce the deviations in the clinical practice according to these protocols, to guide the collection of data, to interpret and manage much better the patient status, and to improve the decision support. Of course, if we are able to computerize this knowledge, we can create systems to activate alerts and reminders for the physicians and the patients. So, if we try to see how to use AI planning for planning the therapy of a patient, we will see that the requirements in this domain are higher than in typical toy problems. And this is due to the unpredictable nature of this domain. So in this domain we will need several specific sub-processes, not only plan generation, but it's really important for the safety of the patient to verify the plan. Of course, we need to provide a visualization of the plan, to execute the plan, to modify the plan, and finally the plan critiquing, which is to analyze if the plan being executed is correct, so it has any problem regarding the original knowledge. So there are several challenges, of course, related to these processes. One of the challenges is the knowledge engineering. We need to accomplish the acquisition of knowledge and the verification and validation. Then we have the temporal representation of management. Many different temporal constraints are usually found in these guidelines. Then another problem is the data integration. We need to evaluate with real data in the hospital databases, and we need to integrate this into the planning domain. And of course, the exception handling due to this unpredictable nature. There are many cases in which the human, the physician, needs to interact with the plan and needs to change the plan according to a specific event that has happened. Another important, or one of the important issues is the temporal monitoring. So in this domain, the states, events, actions, plans, goals, and effects, all of them are constrained by temporal information. And this makes monitoring the states of an event during the execution very necessary. Also, the states model of a plan engine may need to consider more than the plan generation. So it could be needed to suspend the plan or to check if this is completed, what are the conditions for aborting the plan, and so on. So it's not only plan generation, it's more dynamic. And of course the domain is not static, and these unpredictable events can occur, and this depends really on your needs. Of course, in high frequency domains like intensive care unit, this is more relevant, but there are also low frequency domains where the physicians only want to have a plan of the treatment to follow in the next days. Another important requirement is the management of the care team view. So medicine is applied by a team of physicians, nurses, and so on. So we have different roles, and they use a number of resources for accomplishing the treatment. For example, X-ray machines. So the plans to be generated from the clinical protocols may need to consider these institutional constraints, and they should deliver a personalized plan for patients, but also for physicians. So we will explain very quickly a real project that was carried out in the south of Spain. It's called the Oncotherapy. And here in this project, the oncologists were required to apply clinical guidance for treating several patients. And these guidelines, or protocols in this case, they had a lot of temporal constraints. And they have all these requirements that we talk about. They want to have a personalized care process for patients and medical staff, and they want to reduce the time that they spend on preparing this treatment. This is an architecture that considers all the requirements that we talk about. So if we start looking at the numbers of inside the boxes, and we start on number 1 on the left hand side of the screen on the bottom, you can see that clinicians are responsible for defining these narrative guidelines. Then knowledge engineers formalize this knowledge using what is known as computer interpretable guidelines, which are language to computerize this knowledge. Then we have a SIG connector that is able to move from this formal knowledge into a planning specification. For this, of course, we will need to include the connection with the electronic health record from the hospital and the hospital information system. Then, having this specification created and also considering all the temporal constraints, we use a plan generation engine, a planner. In this case, we use a hierarchical task network planner, and we generate a care pathway personalized for the patient. This care pathway can be delivered in the form of a Gantt diagram to the physician. so they can see all the actions following specific time recommendations. And we can also deliver or deploy this care pathway using a business process management engine. This is software to possibly execute the plan remotely, and so each role is each clinician or nurse can enter through this portal and follow the plan. Of course, in number 6 we have another module which is for repairing the plan and for replanning, and this would be needed in the case that we want to include management of unexpected events. So what do we get? This is a fragment of the care pathway that we can have as a result of using this planning technique. So we have the start and end date for each step, the duration, if it's part of a higher level chemotherapy cycle, the oncologist that needs to carry out the action itself, for example, administration of prednisone, which is a drug, the patient, and the dosage of the drug. On the bottom of the screen we can see how to deploy this into a BPM engine so that the physicians can ubiquitously execute this plan. So this is all. Here in the last slide you have some references that you should try to read in case that you have more interest in this wonderful domain. And I hope that you have enjoyed the talk and you enjoy also the rest of the course. Thank you very much.